Once again to the topic for this afternoon, stomach and gut problems. As I said, we're going to go straight ahead because we've been delayed a little bit. And the first thing we're going to do is just receive the welcome address from the founder of Gintervenes. And I'm just going to share that now. Once again, to the topic for this afternoon, stomach and gut problems. As I said, can you hear the sound?
Good afternoon, ladies and gentlemen. Welcome to our webinar, which today is on lung problems. We will continue to put these health information meets together because we believe that it helps our healthcare professional refresh their knowledge, and it also informs the public because, as they say, knowledge is power. When the public is informed, they know what to look for when they are ill and seek help, appropriate help, quickly. And they are also aware of the risk factors so that they tackle them so it stops them from developing these diseases. We have some very distinguished speakers today. We hope you stay through the meeting. There will be ample time for questions.
Thank you very much. Yes, so welcome once again, everybody. That was a quick welcome from the founder of Gintervenes. And I'm going to go straight to introduce our speaker for today. There's still time to invite someone. Just send them a quick reminder that we are online. We have gone live. We have gone live, so share the link with them. Our speaker today is Dr. Owen Wogiren. He's a UK-trained gastroenterologist with extensive experience. He graduated from the University of Benin, Nigeria, and received further training in gastroenterology and endoscopy at prestigious London teaching hospitals. With dual accreditation in gastroenterology and general internal medicine, he served in the British Army for 17 years, reaching the rank of Lieutenant Colonel. After retiring from military service in 2017, he joined the Royal Free Foundation Trust Hospitals as a consultant gastroenterologist. He is currently based at the Barnet and Chase Farm Hospital. He leads the gastroenterology and endoscopy services and specializes in various areas, including gut infections, gastrointestinal bleeding, irritable bowel syndrome, inflammatory bowel disease, and hepatology. Dr. Wogiren is highly skilled in performing advanced endoscopic procedures and holds private consulting privileges at multiple hospitals. Dr. Wogiren, good to see you. Over to you.
Thank you very much for that introduction and welcome everyone. And thank you for hosting me on your site. It's good to see, in fact, I can see some familiar faces here. It's good to see you all and welcome. So I'm actually just going to go straight into the presentation. I'm going to give you some snippets of information on common gut problems. And after that, there will be an interactive session where we can answer common questions and deep dive into any issues which might be trending. Because everyone has a gut, so everyone has, everyone knows what gut issues are about. And some people, understanding their gut issues need to know how to, what to do, what to worry about and what not to worry about. Can you all see my screen?
Not yet.
Okay, so what I'm going to do is I am going to share my screen so that we can go straight into the presentation. Okay. So yes, we're talking about the stomach, we're talking about the gut, we're talking about the digestive system. So everyone knows what the digestive system is. And because like I said, everyone has one. There's nobody in this audience who has not had symptoms in their gut before. Most people have symptoms with their gut and, the symptoms usually go away. So this talk is more geared towards people who have, chronic problems or new problems or worrying symptoms. And, just to give you an insight and possible solutions into tackling the problem. So I'm going to emphasize the significance of your gut health. Now, your gut your immune system actually lives in the guts. Okay, it's got the biggest immune system of the whole body. You have immune systems everywhere else as well. Because most of the pathogens that you come in contact with, they first of all go to the gut, apart from the nasal passages, of course. They go to the gut and they have an impact on our health. So this is just to give us an understanding of how important the health of the gut is. So the first topic I'm going to talk about is bowel cancer. It's also known as colorectal cancer. And people say bowel cancer, intestinal cancer. We use a lot of terms or a lot of terminology for the same thing. And it's a very important cancer, particularly for Black people, because we have a higher incidence, or shall I say, we develop bowel cancer at an earlier age compared to the rest of the world. So it's important that we understand what bowel cancer is. And one of the important things about bowel cancer is if you detect bowel cancer early, you have a 90 to 95% chance of a cure. So it's important we look for bowel cancer, we are aware of the symptoms, and we know what to do when we have the symptoms. So what are the symptoms of bowel cancer? Now, the thing about bowel cancer is most people have had some change in their bowel habit from time to time, especially when you eat something that doesn't agree with you. So is that really important? Now, a change in bowel habit is a persistent change in bowel habit. So if you went out and had something that didn't quite agree with you, and you had an upset stomach for a few days, that's not really a change in bowel habit. That's probably just, food poisoning or acute infection. So if you're having a persistent change in bowel habit that's lasting weeks, and if you see blood in your stool and other symptoms such as abdominal pain or pain in your stomach and unexplained weight loss. Now, losing a bit of weight is normal, but losing, let's say, 5 or 10% of your body weight, 5 to 10 kilograms, depending on what you weigh, that is significant, especially if there's no obvious cause for it. So we need to pay attention to these symptoms so that we don't end up having a diagnosis which could have been avoided or could have been detected a long time ago. So how common is bowel cancer? Now, the thing with cancer is most people think it doesn't happen to me, it always happens to somebody else. But the incidence of bowel cancer is very high. And it's basically, you have a high incidence in men and women as well. It's one of the most common types of cancer as well. And it's a cancer I see quite a lot in my field or specialty. So it's an important cancer. And one of the important things I've mentioned earlier is that early detection of bowel cancer can help save lives. So what are the risk factors? So there's some risk factors we can't do anything about, but there's some risk factors that we can change, like lifestyle habits. So factors that increase the risk of developing bowel cancer include your age. So the older you are, the more likely you are to develop a bowel cancer. And if you have a family history of bowel cancer as well. Some families have history of bowel cancer. So if you have more than 2 people in your family with a bowel cancer, then the chances of you having a bowel cancer is about 1 in 50 compared to 1 in 200 if you didn't have a family history. So you can see that a family history is quite important. Now, some people have chronic long-term conditions of the bowel called inflammatory bowel disease. If you're one of those people, then you're more likely to develop bowel cancer. So you need to be aware of this and pay attention to any symptoms you may have. Now, lifestyle habits, these are the things we can really focus on. So a poor diet, a diet heavy in red meat, smoking, drinking, and lack of exercise and being overweight. These are other risk factors for bowel cancer as well. So these are the ones we tend to address because you can't change somebody's family history. You can't change their DNA or genetic makeup, but you can modify their lifestyle habits. So these are the things we try to look at as well. So screening and diagnosis, like I've mentioned a few times, early detection through screening tests like colonoscopies can help diagnose bowel cancer at an early stage. Now, some people are worried about a colonoscopy and they feel, oh, I don't want to have an invasive procedure, but there are other options as well, which we can discuss later. Now, if you had a bowel cancer, your doctors would decide on your treatment, depending on how advanced the cancer is and where the cancer is. So, we have things like surgery. Most people with bowel cancer, unless it's really advanced, will be offered surgery. Then you'll be offered a combination of chemotherapy on its own or chemotherapy and radiation, depending on the location of the cancer. We normally target and individualize the treatment so that you get the right treatment. Now, in my trust, we actually have immunotherapy. So I work closely with the radiologists, the surgeons, and the oncologists, and immunotherapy, where they actually give you some biologic agents to help combat the cancer, is actually is getting quite important and being developed in the treatment of bowel cancer. Your treatment depends on the stage and the severity. So that's what we have to say about bowel cancer. So if you look at the risk factors for bowel cancer, we have to understand the key factors influencing bowel cancer risk. It says here, age over 50 and above are at a higher risk due to the natural aging process, and of course over the years exposure to potential risk factors. So you can always modify your risk factors, and there's no time like the present. It's never too late. It says here, diet high in red and processed meat. So, if you're somebody who likes to eat protein or likes to eat meat, you don't always have to have red meat. You can have other options like chicken or fish. Those actually reduce your risk of having bowel cancer. The family history, you can't do anything about the family history, but you can be aware of it. So if you know that somebody in your family, and we're talking about first-degree relatives, so these are your siblings, like your mother, your father, and your siblings. Those are first-degree relatives that actually have bowel cancer. So not a distant relative or somebody that you're not quite sure of the relationship between you. So if they have bowel cancer, unless you're closely related, that means you're sharing DNA. You're less, it's not really a risk factor. Then, of course, lifestyle, very important. In fact, lifestyle, number 4 should be number 1. Engaging in unhealthy lifestyle habits, smoking, excessive alcohol consumption, those really increase your risk of bowel cancer. Okay, so we're going to move on here. And management. So the management of bowel cancer, prevention is better than cure. You can't, if by the time you've got bowel cancer, it's a bit too late. But there's surgical treatment, radiotherapy, and chemotherapy. And of course, for those who have family histories of bowel cancer, we have screening modalities. So screening, the gold standard. So if somebody said to me, I want you to do one test to tell me whether I've got bowel cancer or not, I would prefer to do a colonoscopy. Now, some people can't have a colonoscopy for lots of reasons, and they ask, so what's the next best test? The next best test, I would say, you can have a CT scan, and you can also have a stool test as well. Now, most cancers or polyps, which are precursors of things that lead to cancer, they actually give off blood, and we detect the blood in the stool. So the test to look for bowel cancer in the stool is called a FIT test, which in a way, they detect microscopic blood in your stool. So if they find any evidence of bleeding in your stool, then they would recommend you had further tests. We normally go for a colonoscopy, depending on your other risk factors, or we might just go for a CT scan. So that's the number 1 test I would recommend in the community. For those who are over the age of 45, really, sometimes 40, depending on your risk factors, would consider a colonoscopy. So it depends on how fit you are. So colonoscopy, endoscopic examination, or a camera test where we look into your colon and rectum with a camera. It helps detect cancerous growths and cancers. Then the FIT test, which I was talking about, which is a fecal immunohistochemistry test. It's non-invasive, so you don't need to have anything inserted into you. It's a stool test, and it indicates if it's positive, that means there's blood in your stool. Indicates a possible presence of cancer or other gastrointestinal issues. So there are other reasons why you can have a positive FIT test, but that's for people like myself to work out. Then, of course, you have the CT colon. Okay, so that's the end of that topic. So what we can do is take questions now so that people don't get lost in the presentation. So I can take some questions now before we move on to the next step, and probably take questions for about 5 to 10 minutes.
All right. Okay. Thank you for that. If you have any questions, you can pop them in the chat, or you can raise your virtual hand and I'll come to you. So somebody's popped in the chat, consistent constipation, the causes and solutions.
Okay, we're talking about bowel cancer here. So constipation is a separate problem. Constipation is very common, okay, especially in women, because of their anatomy, they're more likely or prone to have constipation. So the first step in tackling constipation is to understand the cause. If you're going to have, if you're going to have a full assessment, the first things I'll be asking you is, what do you eat? When do you eat? And what do you drink? So what is in your diet? Now, if I've looked at your diet and I see you have a good amount of fiber, you're drinking at least 2 liters of water a day, and you haven't had any bowel surgery or any history of problems with the bowels in the past, then I might consider you to have some laxatives for a few days just to tide you over and get you moving. But it's very important. Most people that I treat with constipation, lack of exercise, lack of fiber, not eating the right foods, and sometimes just not even drinking enough water. So those are the first things you tackle. Then you also need to make sure that you have things in your diet which are more likely to let you go to the toilet. So that's how you tackle constipation.
Great, thank you. There are no questions at the moment, so I guess we could move on to the next section.
Okay, so we'll move on. So
Yeah.
the next topic I'm going to talk about is hepatitis B. So some people have heard about hepatitis and a lot of people haven't. So a lot of times I see people with hepatitis B in Nigeria. They come to me because they've had a routine blood test somewhere, usually part of a general health check, and it detects that they've got evidence of hepatitis B in their bloodstream. So it's a viral infection that primarily targets the liver. It causes long-term inflammation and can cause damage if you've had it for a very long time. So there's two types of hepatitis B. There's the acute hepatitis B, which makes you very sick. You become jaundiced, ill, might even have a bit of inflammation in the liver. In fact, not a bit, you have inflammation in the liver. So that most people who have acute hepatitis B means the body is mounting a furious challenge to the virus and is most likely to be cleared. But there's some people who the body cannot clear the virus. So this virus stays in the body for a very long time. And this is a virus that is specific to the liver. So the virus goes to hide in the liver cells. And what it does, it goes into a liver cell, then it replicates or multiplies. Then when it's multiplied, it will now kill the liver cell and release the virus particles to infect more liver cells. So in doing that, which is part of its life cycle, it keeps damaging liver cells. Now the body is very resilient, especially the liver. It will continue to replace the liver cells that are being killed off. But at some point, the body is no longer able to do that. And that's when you start to develop signs of active hepatitis B, which has long-term implications, because if your liver is very inflamed all the time, then you can get scarring, you can get fibrosis, and in the worst case scenario, it's not very rare actually, in worst case scenario, you can actually get a cancer of your liver. So hepatitis B infection is the most common cause of liver cancer in the world, especially in West Africa, or shall I say sub-Saharan Africa. So it's an important infection to know about. And the reason why it's important is a lot of people are walking around with hepatitis B who do not have it. And hepatitis B can be transmitted to your children, and it can be transmitted to your partner. It can also be transmitted to people who are living in close community with you. So you can actually spread hepatitis B. And of course, it's potentially manageable. So it's a good idea to make sure you know your hepatitis B status, and not only yourself, that of your household as well. So what are the symptoms? So most people in sub-Saharan Africa, so most people in Africa, Nigeria, they actually pick up hepatitis B in childhood when they're born. So their mothers have hepatitis B and they give it to them. So it means that as they're growing through from childhood to adult life, the hepatitis virus has been in their system. It's been incorporated into their liver. So the body's immune system knows how to deal with it. But as you get older, your immune system gets older as well, and it gets weaker. So you start to see signs of hepatitis B infection as you get older. So if you had an acute infection, you'd be very sick. You'd have fatigue, you would have jaundice, you'd have dark urine, abdominal pain from a swollen liver, and you feel very, very sick. But most times people have hepatitis B, they don't have these symptoms because they've had hepatitis B practically all their life since birth, so they don't know about it. So the only time we know that somebody has hepatitis B is when they do a blood test or when the liver starts to fail. Then you notice that some of their blood tests are abnormal, their liver function tests are abnormal. And that usually requires review by a specialist. so we can work out what stage of your hepatitis B is and decide how we're going to manage you. So that was hepatitis B. Are there any questions about hepatitis B? The main point for hepatitis B is that you all need to get screened. You all need to know your hepatitis B status. If you do have hepatitis B, then you need to see a specialist so we can talk about how to manage you and whether you need medication for it or not. It's not everyone with hepatitis B infection that needs medication. So back to the audience for any questions before we move to the next topic.
Okay, any questions? Please raise your hand or pop it in the chat quickly. On Hep B.
Okay, can I ask the audience a question then?
Yes.
So how many of us here know our hepatitis B status? How many of us have actually had a hepatitis B check? Can I have a show of hands? Any hands up?
None at the moment.
Okay. So
One,
that means
two, yeah.
Okay. So for those of you who haven't raised your hands, you will need to go and check your hepatitis B status. It's just a simple blood test. Okay, so if there are no more questions, I can move on to the next topic.
Yes, please.
So I want to talk about this condition or this bacteria called Helicobacter pylori. I come to Nigeria and I do a lot of endoscopy, and the first thing I check people for is Helicobacter. And invariably, out of every 10 people I do an endoscopy on, about 8 or 9 of them have Helicobacter. Now, why do we do endoscopies? When I'm talking about endoscopy, I'm talking about a gastroscopy, which is a camera examination of the stomach. Now, lots of people have ulcers. Okay, so they say I have an ulcer, and I ask them, who told you I have an ulcer? The doctor told me. Why? Oh, because I have pain. Now, you don't have an ulcer unless a doctor has told you you have an ulcer, and you don't have an ulcer unless somebody has looked into your stomach and seen an ulcer. So a lot of times we see people in Nigeria that have ulcer symptoms rather than an ulcer. And sometimes when I do look into people's stomachs, you hardly see ulcers, but what you do see is inflammation, which is caused by an infection called Helicobacter. So Helicobacter is a specific bacteria that infects the lining of the stomach and can cause pain. It can cause ulcer-type pain. It can also cause ulcers. And if you have a chronic Helicobacter pylori infection, you can actually develop more problems. It's very rarely associated with cancer as well. So for those of you who are having a lot of ulcer-type pain or ulcer symptoms, rather than just taking medication from morning to night, you need to really be assessed to make sure you don't have an ulcer. And more importantly, if you have other features such as you're losing weight and you're vomiting, to make sure you don't have a cancer. So that's what we need to know about Helicobacter. Now, how do we detect Helicobacter? By doing tests. What are the symptoms? Stomach pain, bloating, nausea. Sometimes people just feel unwell and just have burping or loss of appetite. So it can be non-specific as well. Okay, somebody switched my slides around. It's just on my hepatitis B. Excuse me. Okay, I think when I was fiddling around, my slides were being moved around. Okay, I wanted to talk about the complications of Helicobacter. So peptic ulcers, most common cause of ulcers. Okay, so if you have a duodenal ulcer or an ulcer just beyond your stomach, 95% of the time, the ulcers are caused by Helicobacter. If you have a gastric ulcer or an ulcer in your stomach, about 60% of the time is caused by Helicobacter. So Helicobacter is very common, and you need to understand the impact on your health. That you also have an increased risk of stomach cancer. So I would say that if you're over the age of 50 and you have ulcer, and you've been treating ulcer for a very long time, you need to make sure that you have the right test done to make sure you're not sitting on a cancer, because that's the most important diagnosis to exclude. Okay, so how do you look for Helicobacter? So a lot of Nigerian doctors know about Helicobacter. The problem I have is sometimes we don't really know how to investigate for Helicobacter. The most appropriate test to do for Helicobacter in Nigeria is a stool test. It's something called the Helicobacter stool antigen test. This is a DNA test, so it actually detects DNA of the bacteria inside you. The DNA test is a very accurate test. We also have breath tests, which I don't think are done in Nigeria because they're too cumbersome, and blood tests. Now, the problem with a blood test, I always recommend that if you have a blood test, you probably need to have another test as well. If you had Helicobacter today, you will develop antibodies. Those antibodies are detected by a blood test. The only problem with antibodies is it doesn't tell you whether you have an active infection or you've had an infection in the last 2 years. So I don't really recommend doing blood tests for Helicobacter, though a lot of people still do it in Nigeria. If you give me the results of a blood test for Helicobacter, I will ignore it because I want you to have a stool test, or I want you to have a gastroscopy and a bacteria test inside the body. So remember, if you're going to see a doctor and he's thinking you have Helicobacter, the most important test to consider is a stool test. Okay, so I talked about the second one, which is an endoscopy, where they actually take a sample from the stomach and they can actually detect the bacteria inside your stomach. So this is the most common test which I do in Nigeria. We basically bring the samples and I can test and I can tell you there and then whether you have Helicobacter or not. Now, lots of people don't have Helicobacter, but they have ulcer tests. Or you may not detect the Helicobacter because they've had a lot of treatment and they may not necessarily have got the right treatment, they've just suppressed the bacteria. So it's important to look at your treatment history when I'm looking at the chances of you having Helicobacter. Now, if you've got Helicobacter, what next? The most important thing to be aware of is that you have an infection in your stomach and it needs a course of antibiotics. So the antibiotics we usually use are amoxicillin, clarithromycin, metronidazole. Sometimes you may not respond to these because you're not being prescribed in the right way, or you're resistant to the Helicobacter, or the bacteria is resistant to the antibiotics. So you need to bear that in mind. And I do see people who basically been taking antibiotics for 6 months. You only need at most 2 weeks of treatment for Helicobacter. You don't need to be taking it daily. If you're taking treatment for Helicobacter daily for the last 6 months, chances are the Helicobacter is no longer going to respond to the antibiotics. So your medication has to be supervised by a doctor. There's also a class of drugs called proton pump inhibitors. These are drugs such as omeprazole, lansoprazole, pantoprazole, which help reduce stomach acid. Now, the thing about just taking a PPI or proton pump inhibitor, because a lot of people go to the chemist and they buy the drugs, they feel better for a while, then they stop, then they start feeling symptoms again, they go back, is you need to understand why you're taking it. A proton pump inhibitor on its own does not treat Helicobacter. If you have an ulcer, it will suppress the ulcer, suppress stomach acid, but it doesn't treat you. So if you're having symptoms and you've been having symptoms for a long time, and you've been taking various remedies, including Agbo and all sorts of herbal remedies, which I've seen people take, you need to speak to a specialist so that somebody can work out what you really need to do rather than taking antibiotics for 6 months. Now, the other thing we need to think about is dietary modifications, stress management techniques, avoiding smoking and excessive alcohol, because that can also, even if you don't have an ulcer or you've been treated for an ulcer, you can still have ongoing symptoms because of your lifestyle, eating the wrong food. Now, people say, well, I like my spicy food. I don't have a problem with you eating spicy food, but if spicy food is causing you symptoms, then you probably need to cut down. So we normally individualize our approach to the management of Helicobacter. Okay, so do we have any questions about Helicobacter? Or shall I say ulcers and abdominal pain type symptoms? Because it's very common.
So none on Helicobacter yet, but there were a few on Hep B that came in once you started on Helicobacter.
Okay, I'm happy to go back to Hep B.
Yeah, so someone asked, how is transmission of Hep B? How does it happen?
Okay, you must have seen my slide from earlier when the
And then I think one related to that is hepatitis B transferable.
I was fiddling around and move the slides around a bit. So I'm going to go back to that slide, but just for those who want to capture the slide. Okay, so we talked about management. Okay, so routes of infection. So the most common route of infection really is from mother to child, and that's called vertical transmission from top to bottom. So hepatitis B is endemic in Africa, which means a lot of people have hepatitis B. So women will pass this on to their unborn child. You can prevent this from happening by giving them some special drugs or immunoglobulins at the time of birth. You give it to the child, and it reduces their chances of developing or contracting hepatitis B from the mother. The other reason or the other risk factor which needs to be talked about is blood and body fluids. So if you go to a hospital and somebody's reusing the needle or reusing the instruments and they haven't sterilized the instruments, the chances of you developing hepatitis B is very high. And also when you're having blood transfusions, if the blood has not been screened properly for hepatitis and even HIV, there's a risk of transmission. Then, of course, if you're sharing somebody's toothbrush or razor and there's blood in it and that person has hepatitis B, or you cut yourself with it, you can get hepatitis B there. And that also includes your hair razors as well, your hair clippers. So be very careful. You see, that's the reason why they're putting a lot of, they're trying to sterilize all this equipment. But it's important to remember that your risk of hepatitis B is high if you're sharing implements, you're sharing razors, and you're sharing all those, and you're sharing instruments that have not been sterilized properly. Then, of course, the other one, which is pertinent to adults and those who are sexually active, is sexual intercourse. So if somebody has hepatitis B and he marries somebody who does not have hepatitis B, sooner or later that person is going to develop hepatitis B. Not all cases. There are some people who are married to people with hepatitis B, but the body's immune system prevents them from having it. But that does not mean you should take that risk. So it's something we need to be aware of. Are there any more questions regarding the transmission of hepatitis B?
No more questions on transmission. So let's take those that have raised their hands. Greg, please unmute yourself and please keep it short and sweet. Thank you.
Yeah, good afternoon. My question on the ulcer stuff, when it is cured, can you get it back? I mean, can you be reinfected when you have used all the necessary medication to cure it? Can it come back?
If you're living in the same environment that you were living when you contracted it, you're most likely to get it again. So Helicobacter is what we call a fecal-oral transmitted bacteria, which means you get it from infected water and food. And you also get it from living with people who've got Helicobacter. So if somebody was to use something in your kitchen and they've got Helicobacter, it's not washed properly, you can actually get Helicobacter from them. We feel that most people get it in their childhood when they're less aware of personal hygiene. But you can get it in adulthood as well. And you can also, some people say you can get it from saliva. And the anecdotal evidence is that there's not, it's not really, you don't really get it from saliva, but you can get it from, repeated exposure to people who've got Helicobacter. So yes, you can get ulcers again, especially if you're a smoker or a drinker to excess. I'm not saying you shouldn't drink, but if you're doing it quite excessively, then your body never really has time to heal. So you can get reinfected. You can also have long-standing ulcer symptoms because of a lot of other things. So if you're taking medication that affects the stomach, then you're more likely to have an ulcer as well. So people who are taking things like aspirin, painkillers, and taking them on a regular basis without food in the stomach, you're more likely to develop ulcers and continue to have ulcer pain as well.
Okay, thank you for that. Victoria, again, please unmute yourself and please make it short. Thank you. Okay, I think Victoria's gone off. Christina, please unmute yourself.
Yeah, I just wanted to ask about the treatment for H. pylori. Does it wash out the body nutrients? And if so, should the doctor prescribe prebiotics or probiotics whilst one is on that treatment or after?
It should be after. First of all, antibiotics only act on bacteria. They don't touch your nutrients at all. But remember, the antibiotics are not specific antibiotics. They also kill other bacteria. So you also have bacteria in your gut, which are considered healthy bacteria and don't cause problems. So it's important to remember that if you take a course of antibiotics for whatever reason, not just Helicobacter, you should have probiotics after. Remember, the antibiotics will kill any healthy bacteria, including any probiotics you take as well. So you need to finish the antibiotics, leave it about a week because the antibiotics will still be in the system for a while. Then you take probiotics. Some of my colleagues say probiotics for a month or 3 months. It just depends on your personal circumstances. Probiotics are not cheap, but it's a good idea to try and replace all the bacteria, including the healthy ones that have been killed by the antibiotics.
Okay. Next question, is there a link between H. pylori and cancer?
Yes, there is. So chronic Helicobacter pylori infection can lead to ulcers and can lead to cancer.
Okay. Someone is up.
Me?
Yes,
Yeah,
Victoria, go
Victoria.
ahead.
Yes, please. Do people with ulcer have sharp pains in their stomach?
Yes, you can. When
Because
you have an ulcer, you have all sorts of pain, but
I was tested, but I didn't feel any pain in my stomach, but it's kind of something working around the whole system. So,
yes, yeah, you have all sorts of symptoms when you have an ulcer. Everyone is different. So some people don't have any symptoms at all. They just present with bleeding. And some people just feel unwell. Some people have a sharp pain. Some people have a dull pain. Some people only have pain when they eat. Some people have pain when they don't eat. So your symptoms are very, could be varied depending on your genetic makeup and lots of other factors as well.
All right, thank you for answering that. Next one, is the stool test for ulcer the same as occult blood test?
No. So the stool test for a Helicobacter pylori is called the Helicobacter pylori stool antigen test. This is a specific test that looks for Helicobacter. The occult blood test, if you look at the name, occult blood means hidden blood. So that's a different type of test looking for blood in your stool. We don't really recommend the occult blood test anymore. We do what we call the FIT test, which is more specific. Because if you're to eat something that has blood in it, you can, or you brush your teeth and you're bleeding, you can have a positive occult blood test. So it's not very specific, and technology has moved on to more specific tests like the FIT test. Well, that's a specific test looking for bleeding, which can be coming from polyps, which are growths in your bowel, or from cancer. So that is a cancer test as opposed to a Helicobacter pylori test.
All right, okay. Someone's asking common causes of ulcers.
Okay, most common cause of ulcers, lifestyle, not eating properly, eating the wrong food, eating late at night, going without eating for a long time, drinking a lot of alcohol, smoking. Sometimes I look into people's stomachs, I can tell they're smokers, even though they may not smell of cigarettes, just because of what I see. So lifestyle, very important. Even poor sleep can cause that. And the next factor there is drugs. If you're taking a lot of painkillers on an empty stomach, then you're more likely to have an ulcer than not. So you shouldn't take painkillers, particularly on an empty stomach, and also alcohol as well. Shouldn't be had really on an empty stomach. So those are the most common causes of ulcers. Some people also have some conditions where the body is more likely to develop ulcers, but those are rare.
So leading on from that, someone's asking, with regards to H. pylori, what types of food do you recommend that one eats?
So H. pylori is a bacteria. So it's not about what you eat, it's about your circumstances, your environment. So you can eat anything you want, really. And remember, that's a difficult question, because I could say, don't eat potatoes, and you tell me I don't eat potatoes. So there's no real food that you need to eat for Helicobacter. You just need to have a healthy diet. Don't have a diet that's too acidic or a diet that is basically one-sided. There's some people go for low-carb diet, that's fine. Low carb is better than no carbs at all. So make sure your diet is healthy and balanced as well.
All right, so Bamidele is asking, how do you treat recurrent or resistant H. pylori infections?
That is my forte. You need to come and see me. It's not something you can discuss over the phone or on in a forum like this. Normally, so we see quite a lot of that. The most common people in the UK who have resistant Helicobacter are people who've come from Africa, where you can buy antibiotics over the counter. So most of the antibiotics I've listed there, most people have had them for one reason or the other. So you have to have targeted antibiotic therapy. So normally with the use of a doctor who would take some more tests, sometimes we can actually grow the Helicobacter and it tells us what type of antibiotics to use. Sometimes the reason why it's not worked is because you haven't had it for long enough. So we might give you the same course of antibiotics, but give it a little bit longer. But resistance is very common in Africa and in Nigeria. So you need to use a lot of antibiotics, different types of antibiotics, and also do rigorous testing as well. It's not something I would recommend the layperson does on their own, because you might just end up causing more problems.
Yeah. All right. Okay. So someone wants to clarify something you said earlier. I would like to be sure what I heard concerning the duration of antibiotics taken for H. pylori. Is it 2 weeks or 3 weeks?
Who is giving you 3 weeks? It's normally, so in the UK, 7 days. Okay, so it's 1 week in the UK because people can't just buy antibiotics over the counter. So it's very likely to treat them, and most people are treated with that. In Nigeria, there's a risk of resistance, so we give it for a little bit longer. So if you came to me, and I know you're from Nigeria, you're getting 2 weeks of antibiotics. It's certainly not 3 weeks unless you're having a different type of therapy. So there's no benefit from giving people long-term antibiotics, taking it for 6 months, taking it for 4 weeks or whatever. It's an antibiotic. So you give somebody treatment and you stop and you check to see if it's gone.
All right. Should we be testing H. pylori in children?
I think most children in Nigeria will probably be exposed to Helicobacter. You don't need to test for Helicobacter unless somebody is symptomatic. So I wouldn't say send everyone for Helicobacter. It's not something, that's a public health question. So it's not something I would recommend unless the child has symptoms.
All right. Okay. So one more on Hep B. Can Hep B be transmitted via other body fluids such as saliva and sweat? Then after this, we can move on to the next section.
Certainly not sweat. Okay. So hepatitis B has to go into the body. So if somebody had hepatitis B, I was sweating and I touched his sweat, it wouldn't affect me at all. And of course, the traces of hepatitis B in the saliva and sweat is negligible. It's just like you can't get HIV. HIV is actually, hepatitis B is even more contagious than HIV.
All right. So those are the questions for now. We'll take the rest later when you cover the topics.
Okay, so let me move on to the next slide. I'm trying to cover quite a lot of topics. Normally, I would spend 30 minutes with one topic and we can do a deep dive on it, depending on the audience and the questions. So, IBS. Most people have heard about IBS, and IBS stands for irritable bowel syndrome. It's a chronic gastrointestinal disorder or gut disorder affecting the large intestine, characterized by abdominal pain, bloating, and changes in your bowel habits. So there are different types of IBS. Some people just get abdominal pain, some people get bloating, some people get diarrhea, and some people get constipation. So you have a myriad of symptoms, different types of symptoms in different people. Some people have alternating diarrhea today, constipation tomorrow. So there's criteria for understanding the type of IBS you have. Now, the common denominator of IBS is that most times people have gone to see a doctor. The doctor will look at the type of symptoms you have and say, this sounds like IBS, but because you might have some other features like weight loss or vomiting or diarrhea or blood in your stool, might decide to investigate and look to see if there's anything else. When all your tests come back, then you're more likely to have functional or IBS type symptoms. Now, people call it a diagnosis of exclusion. And I sometimes don't like using that term because people think, oh, it means I don't have anything. You can't find anything, but there's something wrong. So it just means you have a sensitive gut. Some people will drink orange juice and basically have bloating and cramps for the rest of the day. Some people will drink milk and have the same thing. Some people will eat whatever food items it is. We just feel that the bowel is more sensitive and sensitive to things that people can normally tolerate. It could be due to the fact you've been using antibiotics or you've been using medication or you haven't really been eating right for a long time. So IBS is common in young people. And a lot of times in clinic, I will see IBS in people who've gone to the university. So they've left the house, no longer having mothers cooking. They're now eating, or shall I say not eating very well, or even eating at all in university, and they start to have symptoms. It can also be made worse by stress. Okay, a lot of people know before an exam or a stressful period, they can start having problems with their stomachs. So that's IBS type, those are IBS type symptoms. So abdominal pain, discomfort, bloating, either diarrhea, constipation, or combination of both. And some people see mucus in their stool. So mucus just means your bowel is a bit irritated. You might have eaten something that's just irritating your bowel and making you produce mucus. There's not necessarily a sign that there is something significantly wrong. Now, the problem with IBS is it can also mimic other things. So some people can come and say, well, I've been having bloating and I think I've got IBS. But when you look at it, or when you examine them or test them, you can see they've got Helicobacter, or they may have an infection. And the most important thing to remember is that some people have new onset IBS symptoms. That's different. If you've had IBS for 20 years, you probably have IBS. Or if you suddenly had a change in bowel habit in the last 6 weeks, then you're more likely to have something more significant, even like a cancer, and that needs to be checked out. So you can't sit on your symptoms if they're new. So management strategies. I don't think there's anyone who hasn't had bloating or heartburn or a bit of constipation or a bit of diarrhea. So it really depends on your diet. The most important thing that you have to consider is diet. So there's something called the low FODMAP diet, which we normally ask people to try for a few weeks to see if that helps. And basically it's just an exclusion diet. You reduce all the FODMAPs in your diet. There are lots of things, you can Google this, that will tell you what a FODMAP is. So you remove those things from your diet to see if it makes a difference. And what you normally do is, remember, it's a trial of a low FODMAP diet. It's not a permanent diet, because most people, in fact, I've had 2 people today tell me they felt terrible on the low FODMAP diet because they couldn't eat anything at all. So you exclude things one after the other. And some people don't really, they don't really need to sit down and think about a low FODMAP. Somebody told me today, I removed onions from my diet and I'm better. So that's what IBS is like. There's certain things you don't agree with, that don't agree with you. So those are the things you need to target. We do have medication we can use. Sometimes it's painkillers, antispasmodics, Buscopan, Mebeverine. We can even give you something like Lomotil for diarrhea, just depending on what your symptoms are, and also treat constipation. I think the best way to treat constipation is a natural way. So you improve your diet, improve your fiber intake, fruits, vegetables. Don't overdo it. If you start eating a big basket of fruit every day, you're going to get bloating anyway, because your body can't digest all the sugar. So you need to modify your diet in such a way that it benefits you and causes the least symptoms. Stress management, very important. Some people will tell you, my stomach is always rumbling before an exam. Stress management techniques, depending on who you are and what you do. So that's how we tackle IBS. Now, the most people who got IBS are seen by the general practitioners in the UK. I don't see them. I would see people who are really struggling with their symptoms. The first thing I would want to do is make sure they don't have Helicobacter or inflammatory bowel disease, which can give you IBS type symptoms. When they don't have that, I normally send them back to the GP and I say, back to the dietitian, go and look at your diet. Exclude all the things, keep a food diary, and exclude all the things that you have eaten that cause your symptoms. So those are management strategies for IBS, and we can use medication if we need to. So stress, emotional, psychological stress, you need to think about that. So if you're having a lot of symptoms, you need to ask yourself, am I feeling stressed, or do I have moments in my life when my symptoms are worse? Even hormonal symptoms as well. Like women can have hormonal problems and end up having IBS type symptoms. Then you start looking at your food. What are you eating? Are you eating gluten? Are you eating high fat meals? Are you drinking fizzy drinks? Are you eating over spicy food? So if you tell me you've been eating spicy food for the last 65 years and you're fine, then you don't have a problem with spicy food. Or if you tell me you eat spicy food and you run to the toilet every day for the next 2 weeks, then you have a problem with spicy food. People are different. So you need to sit down and work out what you're going to eat and what you're not going to eat. And I've mentioned hormonal changes as well. So you have to identify your approach to IBS. It's always very individual. Some people can't eat certain things. Some people can eat loads of it. And that's how you tackle your symptoms. And I remember IBS is very common, and it's also different from inflammatory bowel disease. Remember, IBS is irritable bowel syndrome, which means your bowel is just irritated with a lot of things, while inflammatory bowel disease means there's an actual inflammation in your bowel. So investigations. So I wouldn't really say investigations. I will call them diagnostic steps. The symptom diary. What is your bowel habit? What did you have the day before? Then we also do blood tests just to rule out infections, anemia, and other symptoms that can also behave like IBS. A colonoscopy is not something I would use freely in IBS type symptoms. We do have stool tests which we can use to find out if there's any inflammation in the bowel. If there's inflammation in the bowel, then we can consider a colonoscopy. But remember, IBS is so common. If I did that on everyone that came through the door, I'd probably be doing colonoscopy on practically everyone that comes to the hospital. So we have to decide what's important and what isn't. Okay, so that is IBS. Any questions on IBS? And just so IBS will sit under the general abdominal symptoms, bloating and all sorts of other things.
Okay, how is IBS related to ulcerative colitis if they are?
They're not related, they're completely separate entities. IBS means irritable bowel syndrome. Ulcerative colitis is a type of inflammatory bowel disease, so they're not related at all.
Okay.
Symptoms can be similar. So when you come to see a gastroenterologist, the first thing I want to do is make sure you don't have inflammatory bowel disease, but your treatment and management is different.
All right. Okay. Somebody's asking about a totally different condition, but I think I will just answer that because there are not many questions at the moment. What gives rise to a mildly active non-HLO associated chronic fundal gastritis diagnosis? And how easy
So what has happened there?
Yes.
Somebody's going to have a gastroscopy, taking biopsies, and they've now come across the histology reports and they're basically asking, can you please convert this to English, or should I say understandable speak? So the most common cause of gastritis is Helicobacter. So that's why they say non-Helicobacter associated gastritis. So the most common cause is of a gastritis is Helicobacter. That's the infective cause. Now there are lots of people who have gastritis, but no infection, no Helicobacter. So too much stomach acid can give you that. Medication like aspirin and painkillers can give you that as well. So it just means the stomach looks inflamed. There's some inflammatory cells there, and that's what they're calling fundal gastritis. Fundus just means where it is. Non-Helicobacter associated means there's no Helicobacter. Gastritis just means inflammation of the stomach. So it's a very common diagnosis. So I look at that and I say to you, you need to have some acid suppressing medication. You also need to watch your diet, because some people go out and eat a lot of chili pepper and come back the next day and the stomachs are on fire. And that's what causes those kind of inflammatory symptoms. But it's very, very different because a lot of people have it and it doesn't cause any symptoms at all. If we find it, we might give you some medication and give you some advice on how not to irritate or aggravate your stomach. But it's not a life-threatening condition. It doesn't cause cancer. If you have ongoing inflammation in the stomach, which is not treated, you can develop ulcers. But the most important thing I would state on there is that you do not have Helicobacter. So you just need to look at lifestyle and possibly use medication where necessary. So that's the answer to that question.
So the second part says, also will ulcer kit serve a good purpose for this non-HLO associated ulcer?
Okay, so ulcer kit is treatment for Helicobacter. Ulcer kit contains a proton pump inhibitor and antibiotics. So unless there's an infection in the stomach, there's no need to use antibiotics. And if you keep using antibiotics, when your body really needs antibiotics, those antibiotics are not going to be effective because your body, whatever it is used to them. So I would not recommend using ulcer kits just to treat that. You can use omeprazole, pantoprazole, and all the PPIs on their own, but not in combination with antibiotics. The only indication for antibiotics is when there's a proven infection.
Speaking of PPIs, how long should someone be on a PPI? There have been discussions about that.
I like these questions. I'm sweating, as you can see. But these are questions I actually tackle every day. So it depends on your symptoms, your age, and what you're actually treating. So if you tell me I've had dyspepsia or I've had gastritis type symptoms for the last 4 weeks, I will treat you with a PPI for a minimum of 4 weeks. Okay. Now, if you come back to me in 4 weeks' time and tell me I'm still having symptoms, then you probably need to have it a little bit longer. So the treatment or the treatment regime for a PPI depends on the individual. Some people have 1 week of a PPI and they're fine. And you tell them, stop smoking and don't do all the things that make you have symptoms. And of course, if you have Helicobacter, treat the Helicobacter. So normally, most people wouldn't need more than 4 weeks of a PPI. If they're having ongoing symptoms, they have other conditions, they're taking aspirin or other drugs which they need to take, which are aggravating the stomach, like steroids, then you'll need to keep the PPIs going for longer. But I try and get people off PPIs within 4 to 6 weeks, and I concentrate on tackling their lifestyle or other issues that might be causing them to have the gastritis symptoms or the ulcer symptoms.
Okay, someone's asking what is a PPI? They might have joined late.
Okay, so I mentioned that earlier. The PPI is a proton pump inhibitor. So it's a specific drug that reduces the secretion of acid by the stomach. Some people with gastritis, especially the non-Helicobacter associated fundogastritis, is caused by excessive acid in the stomach. So what you do is you reduce the amount of acid that is being produced by the stomach to give the stomach time to heal. The problem is we always have to use our stomach, and we're always stimulating our stomach. So if you eat foods that make you produce a lot of acid, like fatty foods, very high in protein foods, the reason why your stomach produces acid is to break down all these complex things you're eating. So if you eat those kind of foods, you're more likely to produce acid. So you need to look at the diet first and use a PPI where necessary.
Okay, let's answer this. There's 2 more questions. Can you please share management of severe ulcerative colitis for alpha thalassemia trait carriers? Let's just
Okay,
answer.
there's no real relationship between ulcerative colitis and alpha thalassemia carriers. The main management for ulcerative colitis, specialist management, is steroids and things like 5-alpha-thalazine, okay? What we call 5-ASAs. So that normally needs to be managed by a specialist. So it's not something that is within the scope of this. This is more of a kind of general talk. So the first thing I would do if somebody's got ulcerative colitis is confirm the diagnosis. Okay, you confirm the diagnosis by doing a colonoscopy and taking biopsies which show features in keeping with ulcerative colitis. Then also depends on the management on their symptoms. Some people have ulcerative colitis and have a bit of diarrhea. So those people you can treat with things like mesalazine, sulfasalazine, and they will normally get better. If the symptoms are more severe, you might need to step up their management. So you might need to give them a course of steroids. Now, what I don't want to see is people who've been on steroids for 6 months without any specialist follow-up whatsoever. They will develop other problems. So the management of ulcerative colitis is best handled by a specialist.
Okay. Can IBS be completely cured?
So IBS is not something that can be cured. You can actually combat IBS and forget about your symptoms. So some people make some changes and their symptoms go away. But there's some people who have long-standing symptoms for a very long time. So it's not a specific disease entity that has a cure. It just has a management. So some people can have IBS in their childhood, and by the time they become an adult, they've got used to it, or the body's grown out of it, the diet has changed, or the body has adapted, so the IBS is gone. So you do see that.
All right, those are the questions for now.
Okay, thank you for challenging me with all these questions. We'll run away soon. Okay, so the next thing I want to talk about is GORD. Americans call it GERD because of how they spell. GORD is gastroesophageal reflux disease. So people who have heartburn, chest pain, reflux, that is what we're talking about. So it's characterized by the backflow of stomach acid into the lower food pipe or esophagus, leading to irritation and inflammation. So your gut or your GI tract starts from the mouth, goes down to the food pipe, which connects to the stomach. Now, the lining of the food pipe is different from the lining of the stomach. The lining of the food pipe is just a channel. It's just a thin line or lining, which just allows for the conduit of food and drink. In the stomach, you have specialist cells which produce acid. So the stomach is most likely is designed to deal with acid. The food pipe is not designed to deal with acid. So if you have acid coming from the stomach to the food pipe, it can cause problems, okay? So the problems we're talking about are inflammation and acid and burning. And what your stomach is telling you what your food pipe is telling you when it starts burning is there is a problem. Okay, because if you didn't have any symptoms at all, then you can get really bad inflammation in the food pipe, leading to strictures, ulcers, narrowing, and even cancer, and a condition called Barrett's esophagus, which I haven't really seen much of in Nigeria, though it does exist. So symptoms: heartburn, which is a burning sensation in the chest, in the area of the heart. So you just feel a burning there. And sometimes people can't tell the difference between a heart attack and heartburn, and that's why sometimes it's called non-cardiac dyspepsia or chest pain, non-cardiac chest pain. So it's important that you don't sit there having heartburn and say, I'm going to go to bed. You need to work out what's going on, take some medication to it. If that doesn't work, then you need to seek urgent advice. We do get a lot of people coming to hospital after they had a heart attack. It's not to say that heartburn means you're having a heart attack. It just means that if it's really severe, not getting better, you need to have it checked out rather than go to bed. Regurgitation, acidic taste in the mouth. Obviously, if acid is coming from your stomach up to your food pipe, there's going to be a problem. It comes all the way into your mouth and you can taste it. Chest pain. Some people have varying degrees of chest pain. Sometimes it's related to problems with the heart, and sometimes it's related to problems with the food pipe. So it's the duty of the doctor to work out what is what. Sometimes you've got so much irritation there, there's a lot of ulceration, and it starts to scar, and you have difficulty in swallowing because the food pipe is narrowed. Some people just have a chronic cough because acid is going up into the mouth and into the lungs, irritating the lungs and giving you a chronic cough. So these are the various symptoms of heartburn. And some people have significant heartburn and don't have any symptoms at all. So it says here, approximately 20% of the population in the United States experience GERD symptoms at least once a week, impacting their quality of life. Most people have had heartburn. They usually know what happened. One interesting thing is that a lot of people who drink Guinness say they get heartburn. So there's some things you eat or some things you drink, and some medication that you can take that dilates or widens the sphincter, opens up the sphincter, and things push back up again. And if you sat there and ate 6 wraps of pounded yam and 2 bottles of Guinness, you have an expanded stomach and you went to lie down, you're going to get heartburn. You're going to get reflux because everything's just going to push up. Your stomach has a limited capacity. Of course, some people's stomachs are bigger than others, but if you're always having symptoms after overeating, it's a no-brainer that you're probably eating too much at a time. So complications, if left untreated, it can lead to complications. Inflammation of the food pipe is very important. That constant inflammation can lead to ulceration. It can lead to a condition called Barrett's esophagus. And what that means is that the lining is so, it's been under attack from acid for a very long time. So it starts to change. You develop new cells there, which are supposed to be in the stomach, but they're kind of changing. And those cells, they're not good cells, because sometimes they can turn to cancers. So it increases your risk of food pipe cancer or esophageal cancer. So it's an important condition to be aware of. So how do we know whether somebody has GERD or not? Normally we ask the question, do you get heartburn after eating? Yes, that's GERD. Sometimes we want to measure the acid that's coming out, and we want to measure the pressure. So that's not something that I think is available in Nigeria. So we normally work around with symptoms and treatment to see if we can help symptoms. Treatment strategies. The most important way of treating your reflux is lifestyle modification. If you're overweight, try and lose some weight. If it's your diet, acidic food, coffee, too much of anything, fizzy drinks, cut those down. Medications such as antacids, the simple ones you can get over the counter, and proton pump inhibitors like mentioned earlier. So proton pump inhibitors reduce acid, okay? They don't stop you from having reflux, they just reduce acid and they soothe your symptoms. If you don't want to have significant reflux, then you have to think about the things that provoke or trigger reflux in you. Some people have got really bad reflux and they have a large defect in the top of the at the top of the stomach, like a hiatus hernia. They may benefit from surgery, but you have to choose people carefully. It's not everyone with a hiatus hernia or anatomical defect that needs surgery. Okay, what are the risk factors? The risk factors: weight gain. Being overweight puts pressure on your stomach, and of course, if there's pressure in your stomach, that pressure is eased by going backwards. Okay, so it goes up into the food pipe, goes into the sphincter, and starts causing problems. Smoking also weakens your sphincter as well. Consuming large amounts of food also stretches your stomach and makes you more likely to have reflux. Certain foods like acidic foods, caffeine, and some people have unusual triggers. Some people say, oh, when I eat this, I get that. So just avoid the things that cause your symptoms. Okay, I wish everyone could just lose weight and look like this lady. Sometimes we have to think of realistic goals. You don't have to lose weight till you're a size 0. You just have to lose weight till you don't have symptoms or your symptoms are better managed. So dietary modifications, weight management, avoid trigger foods. And one good piece of advice is if you're getting really bad reflux or heartburn when you go to bed at night, consider raising the top of your bed. You can use extra pillows, or you can put some props or whatever it is at the bottom of your bed to raise the head up so you don't get acid coming back up. Medications like proton pump inhibitors, H2 blockers, and prokinetics. Sometimes your stomach is so full, it needs to empty. So normally this is what the doctor will discuss with you, your lifestyle, medication, and very, very rarely fundoplication, which is not something that's done commonly in Nigeria, though I do know people who do them. So if somebody's got GORD symptoms, what do? We investigate them first. People who have a lot of symptoms, we might decide to do an endoscopy, or we might decide to do a barium study to help us understand what's going on. Measuring the pressure, called manometry, or measuring acid, called the pH studies, is something that we do in specialist centers. Clinical symptoms is the best way to go. So if you're telling me I drink coffee and I get heartburn, you probably need to stop drinking coffee. You don't need to have exotic, expensive tests. So talking about healthcare strategies for the management of gastrointestinal health, remember what I've talked about is a range of conditions. I've talked about bowel cancer, talked about hepatitis B, I've talked about IBS, and I've also talked about reflux disease. When it comes to cancer, early detection is key. It improves your outcome. And I did say that 90% of people with stage 1 cancer can have a cure if they've got bowel cancer. Regular checkups are important. Don't wait till your symptoms are almost killing you before you go for a checkup. You should have a checkup anyway as part of your adult health management strategy. Adopt a healthy lifestyle. Prevention is better than cure. There's no point having symptoms, all through your life, which are caused by your lifestyle, then now spending so much money trying to make yourself feel better. So just do what you need to do to stay healthy. You don't have to be perfect. Some health, some lifestyle changes are better than none at all. So don't just say, oh, I'm too fat, so I'm never going to lose weight. Try and lose some weight. Even if you can't lose weight, have a healthy, balanced diet. Okay? Don't just drink alcohol because, you just feel that's the only thing that you can do. Just try and live healthy, because what you don't want to do is become an older adult with a very unhealthy lifestyle. So try and maintain your health regularly through your life as you get older. Okay, so here we're going to talk about anything. You can pull any topics up. So these are topics I deal with every day. So I know about them. So I don't really need to refer back to any of the presentations to give you an understanding.
All right. Okay. Do you want to stop sharing then?
Yeah, I can stop sharing.
Okay.
That's the last slide.
Okay. So
people are always asking where they can reach me.
You can pop that in the chat.
Yeah, I'll pop that in the chat later. I can send it to people later.
Yeah.
Okay. So I'll stop the share.
So what is a hiatus hernia? What is a hernia?
A hernia is a protrusion. So there's different types of hernias. When I talk about hiatus hernias, oh, I've got an umbilical hernia. So a hernia is a protrusion or a swelling which is coming out of the body, which is not supposed to be there. So a hiatus hernia means part of the stomach is pushed up or pulled up into the chest, and you now have a gap there. So it's something you see during endoscopy or when you do a scan. And that means that the sphincter or the valve, which is normally below the diaphragm, is above the diaphragm. So it makes you more likely to have reflux type symptoms. So it's a common cause of reflux, or a factor when people have reflux. You don't have to have a hiatus hernia to have reflux, but if you do, then it increases your risk of having it.
Okay. Well, back to heartburn. Someone said I get heartburn when I don't eat on time. How is this so?
Because of acid. If the acid doesn't digest food, it will digest you. So you shouldn't be going out with an empty stomach. You don't have to eat a large meal. I don't do breakfast, but I will have a drink or something just to stop my stomach acid from digesting my insides. So basically, it just means that your body produces more acid, and if there's no food for it to mix with and dilute the acid and carry on with your digestive through your digestive tract, you start to get reflux. And sometimes it might be bile that's causing that heartburn rather than acid. So the bottom line is don't walk around without eating.
Okay. Does constipation cause cancer?
No, constipation is no way related to cancer. It's just a symptom you get because your bowels are not moving. You can get constipated if you have a cancer, which is causing a blockage, but constipation itself does not cause cancer.
Okay. All right. So next one, we have 3 in 1. What are the non-pharmaceutical interventions to narrowing of the bowels, jejunum in particular? I'm sure that's a pharmacist asking that.
I'm trying to understand the question, because when you say intervention, you're asking about something that can be done. When you say narrowing of the bowel, that's a problem with the anatomy. So that question needs to be rephrased because I'm not understanding it. Though I understand the terminology, it doesn't come out to me in a way that I can approach it.
All right, please rephrase question number 1. We'll take the 2 remaining ones. Can Crohn's disease be healed?
So Crohn's disease is a type of inflammatory bowel disease. Crohn's disease can be cured, okay, it can be healed. You can go into remission, but some people always have Crohn's disease. So yes, when you talk about inflammatory bowel disease, it's not something that we will associate with a cure. We call it remission. But you can have inflammatory bowel disease like Crohn's disease today, and after treatment, it can go away for another 50 years. So yes, you can achieve clinical remission or clinical cure or treatment.
All right. If you have any questions, you just raise your hand, please. Is Crohn's disease the same as ulcerative colitis?
No, they're 2 different entities. So Crohn's disease is a type of inflammatory bowel disease, and also ulcerative colitis only affects the colon and is a type of IBD as well. Crohn's disease can affect the stomach, can affect the mouth, it can affect the small bowel, and can also affect the colon. So that's the difference between. And if you look at somebody who's got Crohn's disease, you look at the lining of the stomach under a microscope. The features are completely different, but they're still related, and the treatment is slightly similar, or shall I say similar, with little changes.
Okay. A question about, I think they call them colon washes when people have,
colonic irrigation.
That's the word, yes.
So I don't have a problem with colonic irrigation. That's what works for some people. Some people treat constipation. The only problem I have is who is doing it, because you can perforate the bowel. So it has to be done by an expert who knows what they're doing. And it's not something you actually need. I last recommended the colonic irrigation on somebody who had severe constipation, but it's not something I say you have to have every month. Because remember, you have to have healthy flora in your colon. So if you keep washing it out, then you're more prone to developing problems. And it probably has an impact on your immune system as well.
All righty. And how often, they shouldn't be happening often, but how often?
There's no answer to that question. It depends on why you're having it done. So if you're telling me I have to have colonic irrigation because every few months or so I can't go to the toilet, that's fine. Well, you shouldn't be having it every week, every month. It's not something you prescribe. It's something that you individualize.
Right, okay. Can pregnancy-induced hernia be healed after childbirth?
So think about what a hernia is. A hernia means something has popped out. So the most common hernia you get with pregnancy is an umbilical hernia, which is the one around your belly button. And the reason why it's popped out is because you're carrying something. So once the baby has gone, everything should push back in. But remember, the defect is there. So unless you have another pregnancy and it pops out again, there's no real healing there. It just goes back in. So it's not cured per se. It's just less prominent.
All right, that's fine. Are NSAIDs, non-steroidal anti-inflammatory drugs, contraindicated in people with ulcers?
Yes, they are, because they can make the ulcers worse and they can also make you bleed. So I would not, the first thing I would do if I find an ulcer is stop your NSAIDs. And if you really have to take NSAIDs, we look for the safest NSAIDs that have the less, that have a reduced ability to cause you to bleed, and always on, never on an empty stomach. For taking things like steroids or NSAIDs, you can never take them on an empty stomach. And you also need to take a PPI as well to reduce the acid production. The reason why NSAIDs cause ulcers is because they act on some hormones which protect the stomach. So when they block those hormones, the stomach cannot recover when it's exposed to acid. So that's why they cause ulcers.
All right. And what role do probiotics play in IBS?
So probiotics, some people feel that IBS is due to an imbalance of bacteria. Probiotics try and address that by repopulating your gut with healthy bacteria. Now there's billions and trillions of bacteria in your guts. Probiotics, if you look at most of them, at most will contain 6 different types of bacteria. So it's some way trying to to address the imbalance in bacteria. Healthy foods, things like yogurts, seeds, nuts, anything that contains probiotics is good for you. So that's what it does. It's trying to rebalance your bacteria.
All righty. Mr. Bello, you've put quite a long one in the chat. I've asked you to unmute. Could you unmute and just ask what you want to ask, please? Thank you.
Okay. Thank you so much. A friend recently experienced a heavy hemorrhagic discharge. So, and it was so sudden and without prior medical condition that he lost consciousness more than 3 times within an hour because of the heavy discharge of blood. So eventually was moved to a medical facility and the colonoscopy was carried out, and they couldn't find anything significant except a 2nd-degree hemorrhoid. So what could be the cause of the discharge regarding the IBS?
So the best time to do that test is when he's bleeding, okay?
Okay.
So, and the test should be done by an expert, because I do a lot of those, and I see 2 things. Sometimes they're bleeding from diverticular disease, which is very common, and you can bleed a lot. And the second thing is you could be bleeding from hemorrhoids. So my question is whether he's actually had the colonoscopy report that shows he's got diverticular disease or not. You can get ulcers, you can get blood vessels that bleed, and they bleed heavily and they stop and you don't see them. But if he's got hemorrhoids, I will tackle the hemorrhoids first.
Okay. Okay.
Sometimes we never know why somebody has bled so much, because that's something I do all the time. But if I see diverticular disease, then I know that he probably bled from there or he bled from hemorrhoids.
Okay.
The most important thing is to make sure he doesn't have a cancer.
Okay. So what other tests could you recommend for such a person?
I would go back and have a look at the colonoscopy reports. If I don't find anything there, I will treat the hemorrhoids. I would also do a CT scan to make sure he has not bled from something that has bled into the colon. So if he hasn't had a CT scan, he would need a CT scan.
Okay.
Thank you.
Okay.
All right, Banker, please unmute and ask your questions.
Hello, good afternoon. Thank you for this session. It's really educative. I wanted to find out from you, please. Someone that I know has been diagnosed with Crohn's, colonoscopy is done. The person then the MRI was done and they said the person has narrowing of the bowels. I was just wondering if there's any non-pharmaceutical, should I call intervention, or what can be done to so either to reduce it or to put the bowels back to, not to make it to narrow anymore.
Okay.
At the moment, they put her on azathioprine and also infliximab because of the narrowing. So I'm just wondering, I'm just a bit
okay.
Worried,
so they're using some pretty much specialist drugs. Are they being looked after by?
Sorry?
Are they being looked after by a gastroenterologist?
Gastroenterologist, yes.
Okay, that's great, because that's the first step. So there's 2 types of narrowing in Crohn's disease. So remember, inflammatory bowel disease means inflammation of the bowel. That's the simple thing. When your bowel is inflamed for so long, it starts to shrink, it starts to have scarring. So what's happened is the bowel has narrowed from scarring. So there's two types of narrowing. One is inflammation, where the bowel is swollen, and one is fibrosis, where the bowel is so scarred, there's a scar tissue there, which would never open up again. So my question is from the report of the MRI scan, because as a gastroenterologist, when I send somebody for an MRI scan, I need to know how to interpret the report. That's what I was asking about, who's looking after them. So there's two things you need to find out on the MRI scan. Is this an inflammatory narrowing, or is it a fibrotic or scarring? So if it is scarring and they're symptomatic, you're going to need to remove that part of the bowel surgically. There's no other way around it. If it's inflammation, then it's a medical treatment. So you treat them with steroids, you treat them with infliximab, you treat them with azathioprine. So it appears they're on the right treatment. Now, what they need is what we call an interval scan. So you treat them, they go back and do another MRI scan in about 6 months' time to see what has happened. But if they're having symptoms, they can't open their bowels, they're vomiting, they're in a lot of pain, they need surgery. So that's the answer to that question. So there's no other way. Think about it, a narrowing means it's a narrow. So there's nothing you can do around it apart from tackle the narrowing. It's either you treat the inflammation or you remove the narrowing.
All right. Does lymph drainage help to manage gastric issues?
Lymph drainage is not conventional medical management. So I have no comment on that because I've never seen any person with lymph drainage have improvement of their symptoms. But I wouldn't say stop it. It's up to every individual to decide what works for them.
All right. Somebody has been prescribed pantoprazole to reduce reflux, but after reading the side effects, they haven't used it.
That's an individual choice. Pantoprazole is widely used, commonly used, and it is effective. So that's why I don't like putting people on medication for too long. There is some anecdotal evidence that pantoprazole can make your bones thin, can make you iron deficient. That's for long-term use. If you got reflux and you've got pantoprazole and you're not using it, that means your reflux is not that bad and you probably don't need it anyway. If you got really bad reflux and you can't sleep at night, you will use pantoprazole plus anything else they give you. So side effects. Now people need to understand side effects. If I tell you the side effect of drinking this is headache, diarrhea, and heartburn and pain, it doesn't mean that as soon as you drink it, you're going to get symptoms. So you need to ask yourself, do I want to take this medication or not? And it depends on how bad your symptoms are. So most people who say they have side effects, normally we tell them, okay, you've got side effects and stop. But if you haven't taken the drug, then you're not at risk of having side effects. So you need to understand medication and what we mean by side effects before you electively decide not to take it. Because the first impression you're giving me is that you probably don't have bad symptoms. So it doesn't matter if you take it or not.
All right, Victoria, unmute yourself and ask your question, please.
You haven't unmuted yourself.
All right, we'll come back to Victoria. iPhone, please unmute yourself and ask your question.
Hello,
iPhone,
good afternoon.
very common name, iPhone.
Hi, good afternoon.
Yes,
Good
go ahead.
afternoon.
Good afternoon. Yeah, I've been having ulcer, and I've been taking some bacterial. I've been taking some drugs, but the bones always come from behind.
Sorry, can you repeat yourself? I didn't quite get what you said.
Okay, I've been having ulcer
Mm-hmm.
for the past maybe 5 years now.
Mm-hmm.
And normally I use the gestines and I take more of milk when I have bones. But recently I've been taking some antibiotics, but I still get the bones behind my back.
Okay. Did you listen to the talk about Helicobacter and ulcers? Were you there?
No, I wasn't there.
Okay, I can tell. So first of all, what are you calling an ulcer? You can have ulcer type symptoms, but not necessarily have an ulcer. And the first thing I will do, if you're having treatment for 5 years and you're not getting better, is make sure you don't have Helicobacter. Now, if you have Helicobacter, then you would need treatment for that. But taking antibiotics long-term does not help your symptoms at all. That's why you're not getting better, because that's not the right approach. So what I would say is that you need to look at what's causing your symptoms. Nobody really has an ulcer unless somebody has told them they have an ulcer by looking in with a camera. So you may just have infection there. Yes, you may have an ulcer, but if you had an ulcer for 5 years, you would have serious complications from it. So I would say you probably need to sit down with somebody and discuss your symptoms and your treatment. Taking antibiotics without any specific purpose is not the way to treat your symptoms. You probably have gastritis symptoms. I wouldn't call them ulcer, because I know that's a very commonly used term in Nigeria, but it's not really the term to use. You have gastritis and dyspepsia. So you should have management strategies for that, including the use of a PPI.
Okay. Okay, thank you.
You're welcome.
Okay, Victoria, can you unmute yourself now? All right, while we're waiting for Victoria, any other questions?
Hello?
Yes.
Hello?
Yes,
Oh.
we can hear you.
Yeah, do you recommend I do the H. pylori test again? Because I'm still feeling these irritating movements all over my body, and it's so discomforting.
So have you been positive? Have you been tested positive?
Yes, sir. I was positive for 2 years ago, and you won't believe it. Throughout last year, I didn't feel it at all until very lately. Now the thing, surfaces again.
Okay, you can get reinfection, so it is worth doing a stool test just to see if it's come back or not.
Okay, sir. Stool test.
Yes.
All right. Okay. Thank you very much.
You're welcome.
All right. Next question. Is there any link between gut health and helping children with autism? And if there is, what are the recommendations?
Well, there's a paper, a very controversial paper that says that there's a link between gut health and autism, which was discredited. But there's still research going on that, and people say that children who have their guts can develop all sorts of problems. So that is research territory, and this is not the scope of this conversation to discuss that, because I would have to go back and look at all the current research to see if there's anything that's new.
All right, we're going to give you a break, just 2 minutes while more questions come in. I'm just going to hand over to John. John, are you ready?
Good evening, everyone. Good evening, everyone. Can you hear me?
Yes.
Okay. Thank you, Flora. My name is John Akere Isangbedo. Let me see if I can share my slide or my.
So while John is speaking, please pop your questions in the chat.
So, good evening, everyone.
Good evening.
My name is John Akere Isangbedo, and I'm the project manager for Gentlemen's Healthcare Foundation. We're delighted that you've been able to join us for this health talk and webinar this evening. And we'd like to say a few words on behalf of the Board of Trustees at Gentlemen's and the entire management staff. So first of all, we'd like to say a very big thank you to our speaker, who's done remarkably well handling all of the topics, really very quickly, efficiently, concisely. It's a very, very rich presentation. I'm learning a lot, I'm sure. We'd also like to say a very big thank you to our sponsors and collaborators, our perennial sponsors and collaborators, for everything that they do behind the scenes to make interventions of this sort possible. Most of our interventions are in-person physical interventions, but sometimes we put up virtual interventions of this sort with health talks and webinars. But whatever form the interventions take, they are made possible by donations made by well-meaning individuals, such as those of us here on this call, and maybe other people in a wider circle. So we encourage you to, if you feel inclined, it's possible for you to make a donation, because everything that we do is made possible by charitable donations. So if you want to make a donation to the foundation, you can do so using our website information. Let me see if I can share my screen. Not just our website, our account details. Let's share the screen here.
Alrighty. So while you're doing that, Dr. Walgeren, please, your contact details in the chat as well, please.
Okay, let me just pull them out from somewhere.
Okay.
All right, people. We're giving you time to think of more questions before Dr. Walgeren runs away.
Before he collapses.
You've been drinking water, so you're hydrated, so that's fine. We know
Not
you won't
enough.
collapse.
That's not water, that's vodka.
Oh my God. I need to bleep that out of the recording. John, any luck with sharing?
I seems to have, hang on, let me try again.
Computer is saying no.
Yeah, it's saying entire screen. Okay. It's not even allowing me share at all. I don't know why.
Dr. Walgeren, have you stopped sharing? You've stopped sharing, haven't you?
Yes, I have.
Yeah, so you should be able
it's not
to
allowing me share. Okay,
yeah.
let me see.
Yeah,
Shares.
you should be able to do that. Okay.
It's not allowing me.
Henry will come to your question in a minute.
Let's try it. Good.
So I've just posted in the chat several locations that you can reach me on.
Okay, so for some reason my screen isn't sharing. Can you still hear me?
Yeah, that's fine. Do you want to pop the account details in the chat then?
Yeah, so let me just put the account details in the chat then. Okay.
All right, okay. So we'll carry on with the questions, yeah?
Okay, so when are we terminating this?
Very soon. Right, so is Crohn's disease an autoimmune disease?
Yes, it is. So the bowel is very sensitive to bacteria. So it cannot distinguish between the lining of the bowel and also bacteria. So it attacks both. So it attacks bacteria and it attacks the lining of the gut. That's why you have really deep ulcers, because the body was just eating itself away.
Oh, right, okay. And
that was what my research was on, so I know.
Right, okay. Henry is asking what gut problems can lead to, well, okay, I'll just read it as it's written. What gut problems can lead to kidney problems?
I saw that and it made me think. So you don't really have gut problems leading to kidney problems. You can have gut problems associated with kidney problems. So when you say kidney problems, most of the problems that affect the kidney that come from the gut are usually autoimmune. So it's something like there's an autoimmune problem that also affects the kidneys as well. So it's not something that's strongly associated. It's just something that's known to occur.
All right. You mentioned diverticulitis disease earlier on. What is it?
So as you get older, the bowel starts to change and you start getting pouches in the bowel developing. So those pouches are called diverticulae or diverticulums. And those diverticulums can get infected, and that leads to diverticulitis, which is inflammation of the diverticulum. Usually happens on the left side of the colon, but it's also quite common. So you do see that. If you look on the internet, you see a lot of instances of diverticular disease and diverticulitis. And that's why some of those places that are infected, they can bleed, and you can get a lot of bleeding from there. So if you look, I'm just sharing something on my screen. I'll just share this. You can see what a diverticulum would look like if you're looking inside with a camera. Can you see that?
Yes.
Okay, so those little pouches or little saccules, those are the diverticulae, and they can actually get infected. They can also have trapped stool in there that can cause pain, and they can bleed as well. So that's what a diverticular disease is about.
Okay, thank you. I can't see any more questions. Well, Dr. Walgeren, is there any last message, take-home message you want to leave with the audience?
Healthy gut, healthy living. That's what you need. And of course, and look for your risk factors. And it's surprising that a lot of people still do not know what their hepatitis B status is. So when you're having all your routine health checks and blood checks and all that, hepatitis B screening needs to be done. Okay? So that's my take-home message from here.
Okay, actually, one more question just popped in. So what if you've had the Hep B vaccinations and it still doesn't take, as it were? What do you do?
I will check to see if you actually have hepatitis B. Because some people, the reason why the vaccination doesn't work is because they actually have hepatitis B. So you need to have the correct blood test done to make sure you don't have hepatitis B. There's some people called non-responders, okay? So there's nothing you can do about that. It's just that your body does not develop the immune response which is desired after vaccination. And that's why you're called a non-responder.
And there's nothing that can be done for those kind of people. They
just have to monitor your risk, or shall I say, modify your risk. So don't engage in high risk activities.
Alrighty. Okay, so if there are no more questions, I think that's it for today. Thank you so much, Dr. Wagiran. Thank you, everyone.
Okay.
Thank you, everyone, for joining. I've posted the recording link in the chat. And you can unmute yourself and feel free to express your thanks to Dr.